Good morning, dear students. Today's topic is topography of the trunk, which is a huge topic. It means topography of the thorax, abdomen, and pelvis. In one lecture, it's impossible to include all the important stuff. Today I will try to review as much as possible the topography of the thorax and abdomen, the pelvis. As I mentioned it before, your reference book is this topographical anatomy with autopsy guide and clinical notes from Professor Valenta and Docent Fiala. So you can refer to this. And regarding the topography of the thorax, we already mentioned about the mediastinum in winter semester, if you remember, when I lectured the heart. So it's the slides of the mediastinum is included, the topography of anatomy. I put it here. You will have it here also as a PDF in the MUDr. So as usual, when we are talking about the topography, we have to talk about the borders and boundaries. The superficial boundary is between the neck and the thorax, so it means that the superior or the cranial boundary, it's the line that is starting from the jugular notch, is going over the clavicle, and it's going to the shoulder region back to the spinous process of the C7. Superficial border is not matched with the deep border in the cranial part because the pleural cupula is the parietal pleura, which is covering the apex of the lung, is approximately 1 to 2 centimeters above the clavicle. So a few centimeters is above the clavicle, so it's going to the root of the neck, and it's in the scalennovertebral triangle or the greater supraclavicular fossa. The inferior border, the superficial line, is starting from the xephosternal junction, is obliquely going to the lower edge of the rib number 7 till 12, and it's posteriorly is end up to the spinous process of the T12. The deep boundary, it's the diaphragm. You know that the diaphragm is separating the thorax or thoracic cavity from the abdominal cavity in the deep region. And you know that the right dome of convexity of the diaphragm is finishing at the 4th intercostal space, and the left one is a little bit lower at the 5th intercostal space. Do you know why? Why the dome or convexity of the diaphragm in the right side is higher than in the left side? Yes? It is because of the liver, so because of the position of the liver. So this number is very important according to the deep boundary. So here you can see what I said, the deep border cranially, the apex of the right lung, or which is covered by the cupula. It's going to the root of the neck in the scalennovertebral triangle, so it doesn't match with this superficial border that we have. It's above the first rib and above the clavicle, around 2-3 centimeters up there. And here is the lower border, the superficial one, that is obliquely the line from the xephosternal junction is going to the edge of the rib and is turning posteriorly. And here is the deep border of the diaphragm that we said that the right dome and the left dome, the right one fourth, and the left one is fifth intercostal space. Like other region, when we are talking about the regions of the thorax, we have to divide this region to the smaller area or regions that to explain better the topographic anatomy. For the thoracic region, we have some specific region, the pectoral region, axillary region that we already discussed in the upper limb, the topography, deltoid region also somehow is belong to the both upper limb and the thoracic region. Then the clavipectoral triangle, we already discussed it in the upper limb, and infraclavicular fossa and the lateral pectoral region and inframammary region. So those are the region from the anterior side, and from posterior side, or is the region of the back, is the suprascapular region, the scapular region, deltoid region, interscapular region, and the lateral pectoral region and infrascapular region is the area of the back. And here in the midline we have the vertebral region, and down the lumbar region, so which is it belongs to the abdomen or in the back region. Of course, for the better orientation, we need some lines, and according to these lines, we have to explain the regions that we have it in the thoracic cavity and the thoracic surface or chest wall. We have in anterior side 4 lines. The first line, which is exactly is in the midline, is located, and in the middle of the sternum is located, so it's called the linea mediana anterior. Anterior median line is this one. Sometimes it's called the sternal line. Then the anterior median line here. The sternal line, or linea sternalis is at the lateral margin of the sternum in both sides. The line that is passing the lateral margin of the sternum is called the sternal line. Then we have the parasternal line. The parasternal line is located between the midway between the sternal line and midclavicular line. And midclavicular line is very important line which is passing through the middle of the length of the clavicle down, and in the men it's not exactly, it's approximately, and children it's passing through the area of the nipple, so it's crossing. In women, because of the presence of the breast, so of course it's variable. Then we have the lateral line. We already discussed it, that the axillary region we have threefold. We have anterior axillary line, the anterior fold, the middle or media, it's passing through the apex, and posterior axillary line is passing through the posterior axillary fold. And posteriorly, again, we have in the midline, we have the posterior midline line, which is called the linea mediana posterior. Then the line which is passing through the edge of the transverse process of the vertebra is called paravertebral line. And finally is the scapular line, which is passing the inferior angle of the scapula. So those are the lines that you have to know, and according to the lines we are explaining the projections of some organs inside the thoracic cavity or the chest wall. There are some horizontal lines that also it can help you to orient for the orientation of the topography. The line at the level of the scapular spine is at the level of T3. The line which is connecting the inferior angle of the scapula, it's T7, and the line which is below the 12 ribs, it passing is at the level of the spinous process of the T12. And very important landmark in the chest wall is the sternomanubriosternal junction, which is in the border, in the side, there is an angle, sternal angle, and you know Lewis angle, which is in the sternal angle is attaching which rib? Yes? Second rib, thank you. And this is the level which is approximately at the level of T4, which is a very important landmark for example, bifurcation of the trachea, where the arch of aorta is passing, where the superior mediastinum and inferior mediastinum is dividing, when the superior vena cava is forming, when the arch of azygos is opening to the superior vena cava, and so on. So those are the important landmark, and here there is a table that most important projection of the anatomical structure in the thoracic vertebra is classified for your reference. For example, here is the sternal angle that we said at the approximately is at the level of T45. It is the inferior scapular angle is T7 that we said, and so on. That we have it. So be careful of the position of the opening of the diaphragm, like esophageal hiatus at the level of T10, aortic hiatus at the level of the T12. So those are the important, and the opening of the inferior vena cava in the diaphragm as at the level of T8. Those are the most important landmarks that you have to know. If we talk about the chest wall, that in a while I will tell you the layer by layer. Of course, in the thoracic wall, we have a group of the muscles that we classified them to 5 groups. The thoracohumeral group, those are the group which is connecting to the upper limb. The pectoralis major, pectoralis minor. Here, major, under that is minor, which is enclosed inside the fascia, which is called? Yes? Clavipectoral fascia. Which artery is piercing this? Yes? Thoracoacromial. Which vein is piercing? From superficial is going in the deltoidopectoral groove and is, yes? Cephalic vein, yes? Those are the important that last in the topography of the limb. And some nerves that are penetrating the medial lateral pectoral nerves, also the clavipectoral. So those are the, and serratus anterior. So those are the group. The shoulder and the scapular region, you already know from the upper limb, the muscles of the scapula, muscles deltoid, supraspinatus, infraspinatus, so on. For muscles that they are coming from the neck region, the deep muscles, they are the scalenus muscle. We have anterior medius and posterius, which are innervated by cervical plexus, the ventral branch of the spinal nerve. From the C segment, the back muscle, we divide them to the superficial and the deep one, or the trapezius is the biggest one, latissimus dorsi, posterolaterally, serratus posterior superior and inferior, levator costarum, and erector spinae. And then we have autochtoneus muscles. Those are the muscles that they are originated and they are staying in the place that they are originated. So they are intercostal, external, internal, intimi, and transversus thoracis. So those are the group of muscle that you can find it in the thoracic wall. When you put it in the table for the revision is important. Then there is an artery blood supply of the chest wall, that there are 3 sources for that. One is the subclavian artery, which is giving the arteria thoracica interna, which is approximately 1 centimeter from the edge of the lateral edge of the sternum. If you open and is your task in dissection, for example, if you want find the internal thoracic artery, So you open one of these intercostal spaces, approximately 1 centimeter lateral to the sternal line. So then if you open it, so you can find this pathway of this internal thoracic artery. Then we have the intercostal suprema dorsalis scapulae, the axillary artery giving thoracoacromial branch, superior thoracic, lateral thoracic, and subscapular artery. And finally, the aorta in the intercostal space, you can see that it's giving the posterior intercostal arteries that they are from the third intercostal space till the 11th one. So they are called the posterior intercostal, and the last one is called the subcostal artery, which are giving the cutaneous branch from the lateral cutaneous branch. The anterior cutaneous branch, they are arising from the anterior intercostal artery. This anterior intercostal artery arising from the internal thoracic, and the posterior intercostal, which is arising from the aorta, they are anastomosing here together as you see it in the intercostal space. The venous drainage also more or less is somehow is following the arteries, but in some cases there are difference. So axillary vein, subclavian vein, brachiocephalic vein, and azygos and hemiazygos is the venous system that we have a lecture specifically, the veins of the thorax, that we are going to discuss the details of all of them. So this is the table for the venous drainage, and regarding the lymphatic drainage of the thoracic wall. We talked about the very important 5 group or some books, they write it 6 groups of the axillary lymph node that very important and crucial for the lymphatic drainage of the breast. That also we are repeating, and we said it before. Then we have paraesternal lymph node, which is, according to its name, it's parallel with the sternum, or it's called mediastinal lymph node. Then you have intercostal lymph node that they are located in the intercostal, and the phrenic lymph node, which is superior and inferior, above and below the diaphragm. Those are the diaphragmatic nodes, which are divided to the superior and inferior. So those are the lymphatic. And finally, the innervation of the chest wall is mainly innervated by the intercostal nerves from the segment T10, T1 till T12. And the last one for the ventral branch is called the subcostal nerve, that in the nervous system, hopefully you will have all the details of this time. Intercostal nerves, they are as a matter of fact, just for your orientation, they are the ventral branch of the spinal nerve from the segment T1 till T11, and the last one, which is T12, is called subcostal. That it's crucial and is very important to understand how the spinal nerve is formed and what branches they are given. The intercostal segments of the spinal cord, they don't give any plexus. So this is an exception, that they are segmentally, they are continuing from the intercostal space. But in the cervical region, in lumbar region, in sacral region, as you are familiar more or less, this ventral branch of the spinal nerve from these segments, they are going together, and they are mixing together, and they make the plexus as a cervical plexus, brachial plexus, lumbar plexus, and sacral plexus. That extremely important. A small area of the thoracic chest wall is innervated sensitive innervation of the skin exactly below the clavicle by the supraclavicular nerves that they are arising from the cervical plexus, from the Erb's point or punctum nervosum down, and they are going over the clavicle. So if you get the chest wall and you are going to dissect, so you have to know layer by layer what layer you have. First layer, of course, is the skin, that it's under the skin. Then it's the subcutaneous connective tissue, which is variable individually. They are composed of the fatty tissue or adipose tissue. In this area, then in the female, you have breast or the mammary region, which are in this breast region, the skin is becoming very thin. And in the males, instead, they are composed of heavily hairy in the nipple area and sternum area. They are full of this hairy hairs or hair follicles and hairs. This skin is protecting the underlying structure. As we said, that after the skin is the subcutaneous connective tissue, which is above the sternum, is becoming very thick. Then the fascia that is existing in the chest wall, and they are covering either the muscles or the other organ. They are one superficial fascia, which is call it thoracic fascia, and is covering the muscles. Then we have the clavipectoral fascia, which is between the clavicle and pectoralis minor, is located, and it's a deeper fascia. Then there is very important fascia here after the muscles, and exactly in the inner side of the thoracic cavity, you have the endothoracic fascia, which is above the or in the superficial to the parietal pleura is located. And there is one fascia, it's called Simpson's fascia. It has a terminology, which is the reinforcing of this endothoracic fascia at the region of the apex of the lung, which is from the first rib is going through this cupula to the transverse process of the C1. So those are the fascia, and then it's very important space that everybody must explain. This space is intercostal space, and is one subject that you are going to dissect, and you find these structures. This is intercostal space, and according to its terminology is the space between the ribs, intercostal space. This space is between two muscles. If you remember, we mentioned three muscles: external, internal, and innermost or intimi intercostal muscles. But this space is and the vascular bundle that you have here, they are located between just two of them. One is the internal intercostal muscle, the other is innermost intercostal muscle. So between these two muscles, you have three structures that exactly below the ribs in the region of the costal groove, the groove of the ribs, they are passing, and they are posterior intercostal vein, posterior intercostal artery, and the most inferior one is the intercostal nerve. So remember, the arrangement from upward till downward is VAN1. Remember always, vein, artery, and nerve under the ribs in the region of the costal groove. So they are passing of that. Above the following rib, you have another vessels that they are called collateral branches, or also they have terminology as a supracostal branches, and they are artery and veins, and also the nerves they are passing, and they are going above the following ribs and at the level of the costal angle. So those are very weak branches. So that's why if you want to, for example, puncture the pleural cavity to take some sample of the fluid, for example, that there, so the puncture, it will be going over the lower rib. So is obliquely is going, and the puncture, it will be like this, and a little bit obliquely, and is penetrating. So never do the puncture through of the chest wall below the rib, which are the intercostal neurovascular structure. They are located, and mainly the nerve, which is immediately under the groove that it is. So this is important, and here you can see another picture of the layer. So skin, subcutaneous connective tissue, superficial fascia, the muscle. Then you have the three intercostal muscles, and between the internal and innermost, or intimi, there are these three intercostal vein, artery, and nerve. They are passing here. Here is also another picture. And above the following rib is the collateral branches, or the supracostal branches that are located here in this region. And here is the recapitulation again. For that one is very important. You see that this is aorta, which is giving the posterior intercostal. This is the azygos vein that is draining the posterior intercostal back. And those are the intercostal nerves that we said that they are the ventral branch of the thoracic segment of the spinal nerve. So they are going between these two muscles, the intimi and intercostalis interni. And in the lateral side, they are giving the lateral cutaneous branch for the sensitive innervation of the lateral part of the trunk and the supplying of the blood vessels. And vice versa, from the anterior side, we said 1 centimeter, 1 or 2 centimeter lateral to the margin of the sternum. You see that the internal thoracic artery, do you know the branch of? Internal thoracic arteries branch of, yes, David? The? Who? What? What do you say? Yes, subclavian. So it's giving the subclavian, and here it's giving the anterior intercostal artery that they have anastomosing together with each other, and here they are giving the anterior perforating branch of the intercostal for the blood supply and sensitive innervation of the anterior aspect of the chest wall. And here is the same, the cross section that is making the walls, and then when you go inside, then you have between the parietal and visceral pleura, you have the pleural cavity, and between the pleural cavity, there is a space which is called mediastinum that we had it in the winter semester. One region that already I mentioned is peristernal region. It doesn't have so much structure, so those are the region that is in front of the sternum, yes? So if you touch it, so you see that there are no much structure. So first layer is skin, which is the skin here is very thin, and it has a lot of sweat glands, and in the male, there are some hairs is located here. Then we have subcutaneous, which is also is very thin. It doesn't have so much fat. And then you will reach to the bone, which is a sternum. And you know that the sternum, it has the 3 layers, the external compact, internal compact, and between them there is a spongy bone of the sternum, which is very important for the sample of the red bone marrow. So the aspiration of the red bone marrow, it's happening either from the sternum or you know another place that they are taking the bone marrow sample? Is very important for diagnosis of the, for example, blood cancer. So they take the bone marrow and they see. It's very painful, of course, but no other choice. Yes? The hip bone, exactly. In iliac crest, also they are taking it. If there are a lot of fat in this region, so we choose this sternum, and always it must be in the midline, and never do the puncture at the sternal angle. Why? Anybody? Sternal angle is the place which is the manubrium and the body of the sternum. They join together. It's called manubriosternal synchondrosis. It's a cartilage. So it might not be ossification happening. So when you do the puncture, the needle and stay the cartilage, you penetrate the through the cartilage, and the needle is going and is going and is going either to the heart or pleural cavity. So instead of bone marrow sample, you will have sample of something else. So it's important not to do it in the second intercostal region or the second ribs. So it must be between the third till fourth here in this midline. So this is just one. So then when you remove the sternum, behind the sternum there is very small muscle which is called musculus transversus thoracis. And then you will reach again to the endothoracic fascia, which is, if you open this endothoracic fascia, then you will reach then to the deeper structure of the thoracic cavity, which is mediastinum. And as I mentioned it before, so here approximately 1-2 centimeter lateral to the edge of the sternum, if you find the passage of the internal thoracic vessels, vein and artery, so you go in the parasternal line and you open the window in this area and you can find the course. And this internal thoracic artery, it's giving the end branch, which is called superior epigastric artery, which is anastomosing, is extremely important, which with the inferior epigastric artery, which is a branch of the external iliac artery. And those two arteries, they are anastomosing, and you can find it behind the rectus sheath. So if you find the rectus abdominis in the abdomen, behind, if you cut it, and one of the topic of the dissection, and one of the interesting structure that we use it for the dissection exam is the inferior epigastric, which is behind the rectus sheath, is going upward and is anastomosing with the superior epigastric. I will go back to this subject again in abdomen. Another region of the thoracic region is breast or mama. This breast, as you know, is consisting of the lobulated gland that they are called the glandula mammaria, and a lot of adipose tissue. This adipose tissue we are dividing to the peremammillary adipose tissue, which is in front, is making the region of the in front of the pectoralis major muscle, and the other one, except this areola, which doesn't have the peremammillary fat tissue, and behind you have another fatty tissue which is called retromammillary fatty tissue, which is separating the breast from the deep fascia and providing allowing the movement of the breast again the deeper area. The axilla, the breast is laterally and cranially, it has one process which is called the axillary process. So this is the axillary process which is going toward the axilla. This is another part of the breast that you have to know. There are some ligaments which are called suspensory ligaments, Those ligaments that they are starting from the skin of the breast, and they are going through all this fatty tissue, and they are connecting the gland to the pectoral fascia. Is the fascia which is covering the pectoralis major mainly, and this ligament is called suspensory ligament or coperi. Then the shape and the size of the breast, you know that is variable and is individual, and it depends on the amount of the fat and the connective tissue. We are explaining if there is and is of course is changing by the age. If it's flat, it's called discoid breast. If it is spherical, it's called spheroid mama or breast, and if it's like a pear shape, it's called piriformis. And in the age which is under the breast is making a groove as a submammaliar groove, so it's called pendula, mama pendula. This structure inside the gland of the breast, they are consisting or composing of the lactiferous ducts, around 15 till 12 till 20 lactiferous ducts. They are located inside, and these ducts, they are connecting together to the center to the area which is called the sinuses here in this area. And these sinuses, finally, they are open to the nipple. This nipple is pigmented, of course, and it's called areola. And we said that here it doesn't have any adipose tissue. It has very tiny apocrine gland, which is called Montgomery gland. And this nipple in the men and children is the landmark for the fourth intercostal space. So this is, but in female, of course, it's not constant because of the shape and the size of the needle. The artery blood supply of the breast laterally by the branches of the axillary artery, superior thoracic, thoracoacromial, lateral thoracic, and subscapular artery. Medially, the other side is by the branches of the internal thoracic artery. And second till fourth intercostal artery, they are giving some perforating branch, this laterally, that it's giving the blood supply. The venous drainage, again similar to the artery, axillary, internal thoracic, and internal intercostal vein. Innervation of the breast via this anterior and lateral cutaneous branch that I said, from the second till sixth intercostal nerves. Second till sixth intercostal nerve, which is approximately is the area that the mama or breast is located here, is the area that is innervated. And the nipple is, as we said, because it's located in the fourth intercostal, so it's innervated by fourth intercostal nerve. The lymphatic drainage, you had it in the upper limb in axillary region. The details, you have the slide. There are 5 till 6 group of the lymph node that they are very important for the diagnosis of the breast cancer. And as we said, the nipple and the areola, they are located in the fourth intercostal space. Then we know, or you know, that the thoracic cavity. So it was all information about the chest wall and some important area and the region that we already discussed. Then we go to the deeper layer of the thoracic cavity, and we reach to this space, and we will find some organs. These cavities, either they are serous cavities, which are mainly either the parietal and between the parietal and visceral pleura, which is called the pleural cavity, which is lung is located there, or there is a pericardial cavity that, as you know, it's between the, of course, also the serous pericardium also is located the hearts that you have all this lecture before. Then the parietal cavity and pericardial cavity, and between these two pleural cavity, there is a space in the middle of the thoracic cavity which is called mediastinum that we already, the details we called the classification of the mediastinum we discussed, and I put it here in the slide for the revision. We are going to discuss about the pleural cavity that the border superiorly is, as we mentioned it, is extend above the clavicle, approximately 2-3 centimeter above the clavicle, and there is a place that the copula, it reached to the root of the lung at the supraclavicular greater or the major supraclavicular fossa or scalenvertebral triangle. Inferior border is extend to the level of the costal cartilage and diaphragm, and the medial wall is formed by the mediastinal parietal pleura, which is bordering the mediastinum here. So all the thoracic cavity that you want to discuss is divided by pleural cavity in the side, which is between the visceral and parietal pleura, and between the two pleural cavity, this space is called mediastinum, that we divide them to superior and inferior mediastinum, and inferior mediastinum is farther by inferior anterior, inferior middle, and inferior posterior mediastinum. And if I ask you, heart is located in which mediastinum? Only one? Yes? Heart? 2? Heart? 3? 4? 5? You break my heart. Yes? Anna? Middle mediastinum, yes. So inferior medial, middle mediastinum, that we discussed. So regarding the topography of anatomy, you know about the lung, the structure in the lecture, and the pleura, but topography of the pleura, you have to explain where is the pleura. Started in the anterior side and posterior side. The pleura is starting from the copula. Copula, it's the parietal pleura, which is covering the apex of the lung. Is projecting to the first rib, as you see here, first rib. Is in anterior side, is going to the clavicle here, and from the major supraclavicular fossa, it's going down. When it reached to this clavicle and is going down, it reached to the sternoclavicular joint, and parallel with the manubrium of the sterni is reaching to the second rib where the sternal angle is located. So both lung here in this area, they are the similar pathway. Then from this second rib that is attaching to the sternum, they are going approximately parallel to the edge of the sternum or in the midline. Sometimes these two, they are reaching to each other, and they are going down till the fourth rib, which is attaching to the sternum. Then from here, it's making obliquely curved and diverge these two pleura from each other to the side, to the left and right side. And in the right side is curved outward, and it's going to the approximately at the level of the rib here, which is the rib number 8 and 9 rib. And in the left side also here is going obliquely posteriorly. Between this line or contours that we discussed here is the inferior border that I will tell you exactly in which level you can find the inferior border. Between these anterior outlines of the pleura, you have two spaces here. One space in superior and one space is in inferior. Do you know this space is for what? Behind the manubrium in superior mediastinum, if you break the manubrium and you go behind the manubrium, you see the first structure in the superior mediastinum, which is 1, 2, 3. Yes. Thyroid? Neck? But you were close. Thymus. Yes, it's the first superficial structure if you want to find the thymus. So you, behind the manubrium of the sternum in superior mediastinum is the first structure. Of course, in children, it's much more bigger. But in dead body that we have, usually they are old, you don't see the exact thymus. You see the thymus, the remnant of the thymus, which is a fatty tissue and connective tissue, which is after the involution of the thymus is located, yes? So that's why here in the superior interpleural area, this is called thymic area. And down in this area is located yes? Heart. This is called pericardial area or pericardiac area. So, intermediate space between the anterior pleura here and here, the area interpleuralis superior or the thymic area, area interpleuralis inferior or pericardiac area between the fourth and fifth and sixth ribs here. Then it's very important to know the inferior border of the pleura. Inferior border of the pleura. Here is dot line, it's the pleura, and the whole line, it's the contour of the lung. So this pleura, when it's going obliquely down, they make the inferior border, and this inferior border, it has some projection, and you are using the line. So we ask you, for example, in mid-clavicular line, which is passing from the middle of the midpoint of the clavicle down, you will reach to the 8 ribs in this region, the inferior border of the pleura. In mid-axillary line, which is in the apex of the axilla, if you go down, you will reach to the lower margin of the pleural cavity, it reach to the 10th the costal cartilage. And in the scapular line, which is posteriorly, is passing through the inferior angle, the inferior border is reaching to the 12 ribs, sorry, here is the pleura, and continue to the spinous process of the T12. So those are the projection of the parietal pleura or the pleural cavity in the inferior border, and it's very important to know these numbers because when you are listening to the lung, you have to know where is exactly the position of the lobes. And for better understanding, we said that the apex of the pleura, it's above 2-3 centimeters above the clavicle, is covered by the cupula. The anterior border, we said the lines that they are passing. Inferior border, we said that it's the passing, but lung projection is different than the pleural projection. So the upper one and medial border, they are more or less, they are copying the pleural cavity, this bluish color. And the purple color is the border of the lung. And as you see, the inferior border of the lung here is finishing, but inferior border of the pleura finishing here. So usually one or two, usually two ribs, they are higher than the approximately is 5 centimeter. They are higher than the pleural border, the inferior border of the pleural cavity is located, and those are the passage of the projection of the lung in inferior border. Then it is very important to recognize the oblique fissure that you have it in the both lung is coming, and horizontal fissure. Horizontal fissure is very important landmark that in next slide I will show you. It's the fissure that is in the only in the right lung you have, and this is passing alongside the rib number 4. So this is very important. And for the oblique fissure, it's going obliquely and is curving obliquely at the approximately downward and forward to the rib number 6 and at the parasternal line. So to recognize of the oblique fissure and the horizontal fissure, you will ask the patient to raise hand and put the arms in abducted position and put it in the posterior back side of the occipital region. Then this medial margin of the scapula, it can be a landmark for the passage of the oblique line. This is one. And second one, if you do it from the lateral side, and here is the line which is called mid-axillary line, you can see that this oblique fissure is starting at the level of the T4, and then it's going inferiorly to the level of the rib number rib 4, and then rib 5, and then it's paralleling with the passage of the rib number 6, as you see here, the oblique fissure. And horizontal one, it's following the passage of the rib number 4, which is very important landmark in this region, as you see in this slide. Here is repetition of the oblique fissure, horizontal fissure, yes. And then there is a projection of the hilum or hilus of the lung, which is anteriorly is projecting at the level of the third intercostal space near to the sternal border, and posteriorly is projecting at the body of the T5, T7, the hilus or hilum of the lung. Just for the recapitulation of the pleural cavity and the parietal pleura, you know that parietal pleura has 4 parts. The parts that is covering the apex is called cupula. The costal surface is pleura costalis, behind the ribs. Then the lower part, which is covering the diaphragm, is called diaphragmatic pleura, and the medial side, the border of the mediastinum, is the mediastinal pleura. So the place that there are this mediastinal pleura and diaphragmatic pleura, they are connecting together. They make the recess, which is called costo-mediastinal recess, and the place that the costal pleura and diaphragmatic pleura, they are connecting together, is called the costo-diaphragmatic recess. This is extremely important because it's the deepest part of the pleural cavity that here in the mid-axillary line, it reaching to this level of the rib that you can see here in this region. About the mediastinum, we have this lecture in winter semester. I just put it here for revision. As we said, is the sagittal space between the 2 pleural cavity, left and right. If you want to say the superior border of the mediastinum, what is the superior border of mediastinum? It's not difficult. It's written superior thoracic aperture. What is the inferior border of the mediastinum? Diaphragm. What is the posterior border of the mediastinum? Is vertebra, thoracic vertebra from 1 till 12. Yes, and the ribs that they are attaching to this vertebra. And what is the lateral border? Is, we said, what is this? Yes? Mediastinal part of the pleura. Yes, mediastinum pleura. And what is the anterior border? Yes? Sternum. Sternum and the ribs that they are attaching to this. Yes? And we said that at the level of approximately T4, T5, there is a line which is passing through the superior part of the heart. This line separating the mediastinum to the upper portion, which is called superior mediastinum, and the lower portion, which is called inferior mediastinum. And inferior is according to the place of the heart. In front of the heart, behind the sternum, is anterior inferior mediastinum. The heart is located as a middle mediastinum or inferior medial mediastinum. What is behind the pericardium of the heart? Here they are called posterior mediastinum or inferior posterior mediastinum. And then, of course, we said that from the superior mediastinum, if you dissect, the best one is in this cross section. You can see we have 4 main layers. The first layer that, as I mentioned, if you reach to this sternum, that we said that is peristernal part, then it goes the sternum, and behind the sternum you see thymus. After you remove the thymus, the second layer from superficial to deep. The second layer, there are venous layer. They are the biggest, largest vein that they are connecting together, and they form the superior mediastinum. Then the third layer is arterial layer, and those are the arteries that they are branches of the arch of the aorta. That they are going, they are the 3 main branch, and finally the last layer after you removing this arterial layer is the trachea and bronchial layer. So very important, if you go to the dissection course and you have the task of the superior mediastinum, so we usually remove the sternum. Yes, we cut the sternum, we break the ribs attaching, and we remove the sternum to reach to the deeper area. So after immediately you remove the sternum in superior part, in superior mediastinum, which is border is, what is the posterior border of the superior mediastinum? If somebody answer, it means that he understands the, yes? Posterior border. That is superior border. Yes. Yes, vertebra T1 till T4. So if somebody write T5, 7, 8, 9, so then is inferior mediastinum. Yes. So here is then vertebra. There are, of course, 2 very important nerves. They are passing from the neck region to the superior mediastinum, and one is vagus, and the other one is the phrenic nerve that they are passing through the superior mediastinum. Together, also some course of the thoracic duct from posterior mediastinum, it reached to the superior mediastinum. So those are the content, and I just skip this lecture. You have it in the winter semester. Be careful, be careful, be careful about the passage of the recurrent laryngeal nerve. Recurrent laryngeal nerve. Recurrent laryngeal nerve in the left side is turning around the arch of aorta, yes, under the ligamentum arteriosum, and is going upward recurrent. It means back to the neck, between the, in the fissure between the trachea and esophagus, and is going upward toward the larynx and is supplying all muscles of the larynx except, yes? Cricothyroid muscle, which is innervated by the superior laryngeal nerve. And also the recurrent laryngeal nerve is innervating the sensitive innervation of the larynx below the level of the vocal cord down. This is very important. And what about the right side? Right side, we don't have arch of aorta. The recurrent laryngeal nerve is a little bit shorter. It's making a loop around. Yes? Subclavian artery. Around the subclavian artery in higher level, so that's why you don't see the recurrent laryngeal nerve in the right side in the superior mediastinum. Around the subclavian is going upward and is again between the trachea and esophagus is going upward there. So left recurrent laryngeal, it has a longer course. It's going to the superior mediastinum and it's going to the around the arch of aorta. So the operation, during the operation of this area, the surgeon must be absolutely be careful of this area. About the phrenic nerve also is important that it passing on the pericardial surface of the heart. All these things is explained in the lecture in the winter semester. I just passed through. Yes, just to remind you, one of the other topography of the thoracic region is projection of the heart that onto the chest wall, and it's called testut point or auscultation point. So point A, B, C, D, or TMP, they are explaining the position of the aortic valve, tricuspid valve, mitral valve, and pulmonary valve. This is very important. The apex of the heart is projecting to this place, the fifth intercostal, at the level of the mid-clavicular line, or 8 centimeters from the median line that it was passing through the middle of the thing. So this is projecting the apex of the cordis. So that is very important also for the topography of the heart. Then is abdomen. Break. Okay. 10 minutes break. 9:15 we start. So we continue the topography of the abdomen. I will try to talk about the most important things in the slides. There are too many slides, and the important things they are highlighted for you. As like a thoracic region that we classify those regions to the smaller region to explain the area, the abdominal wall or abdominal cavity, also it's subdivided to the different region. For example, epigastric, hypochondriac, umbilical, pubic region, lateral, and the inguinal regions. Those regions, as you see, they are divided thanks to some lines that you see here. That's why, like a thoracic region, that you had this vertical line, and according to this vertical line, for example, we said the projection of the pleura and projection of the lung and the other organ. These lines also is important to classify this region. Before we start with the abdomen lines, the reference lines, we have to say again the border of the abdominal cavity or border of the abdomen. Superficially is the same border of the lower border of the thorax. So it means that laterally is bordered by the posterior axillary lung, and it's going along the lower edge of the of the lung. The deep boundary, it's making as a diaphragm, is the same. So the upper border of the abdominal cavity is diaphragm. Again, in the right side, the dome of the diaphragm in fourth intercostal space, in the left side in the fifth intercostal space. But the lower surface of the abdominal cavity is against the lower limb. So there are the lines that going from the iliac crest to the anterior superior iliac spine, and then it's going as an inguinal groove and separating as a linguinal ligament, separating the lower lip from the abdominal cavity, and in the middle line is the upper edge of the pubic symphysis. So the lower surface or lower border, lower part of the abdominal cavity, it reaches to the pelvic cavity. So we have the pelvic cavity also in the lesser pelvis, it's reached to that. So back to this line, or the reference line that it's used in the classification of the regions of the abdomen. We have several horizontal lines that in different reference they are taking different these lines, but the most important of them is xiphoesternal line is the line which is between the synchondrosis of the body of the sternum and xiphoid process. Another very important line is transpyloric line or plan, that it's between the midway between the jugular notch of the sternum and the superior border of the pubic bone. So approximately at this midline of this length, so there is a transpyloric level or the line, and this line is passing at the level of L1 vertebra. This is very important landmark, and is dividing the anterior trunk wall to the upper part and lower half, and the transpyloric line, they call it because it's passing through the pyloric part of the stomach, and it's approximately in this level. Then there is a subcostal line, and this subcostal horizontal line is passing through the lowest point of the costal arch. So connecting these two costal arch, and of the approximately is rib number 10, and at the level of the L2 vertebral body is located here. And this is the line which is separating the epigastrium from the mesogastrium that we are going to discuss. Then here in the lower part there are three lines that mostly they are using this interspinal line, which is the connecting of the anterior superior iliac spine together, and the other one is the supracrystal line, which is passing through the body of the L4 here, and it's connecting the highest part of the iliac crest of right side to the left side together. And intertubercular line also, it's the connecting of the iliac tubercle, which is passing to the level of the L5, sorry. So these lines, they are of course variable according to the respiratory position of the diaphragm, is according to the age, sex, so they are not exactly exact landmark. Those are the orientation line. And here you can see the subcostal line that is passing here, and here is, you can see the bispinal line. And also, in addition, you have vertical line also. So vertical line is extension of the medioclavicular line that we studied in the thorax. They are coming down and is passing through the approximately the nipple of the men, and it's coming and is crossing the costal cartilage of the rib number 9, and it's continue to the center of the, or midpoint of the inguinal ligament. This is a continuation of the medioclavicular line, is the vertical line, and also this line is in abdominal region, is showing the edge of the rectus abdominis muscle. If you find this six-pack that you have, if you see this rectus abdominis, and the edge of the rectus abdominis is, as a matter of fact, is the same line, vertical line that you have it also. So either is continuation of the medioclavicular line to the midpoint of the inguinal ligament, this is one vertical line, or you can say the edge of the rectus abdominis. There are two lines, one line which is exactly the continuation of the anterior median line, which is in the midline, is going and is continued to the center of the pubic symphysis. It's called linea mediana. It's from the xiphoid process to the umbilicus in the center and the pubic symphysis. And the other is transumbilical line, which is horizontally passing through the umbilicus that we are going to show you. So some of these lines is using for the different classification of the abdomen. We have two classification of the region of the abdomen, two way for the classification. One is 4-quadrant pattern. So you use this line that I mentioned, linea mediana or median line, which is coming from the xiphoid process, is passing through the center of the umbilical and it going to the center of the pubic bone. So this is a vertical line, and the horizontal line is the transumbilical line, which is passing through the umbilicus, and in this case, thanks to these two lines, you have 4 quadrants. Then you have to say, if you want to explain something, you will see to the right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. This is one of the explanation. They use it in clinic also, that, for example, you see some pathology, and you say this pathology is located in the right lower quadrant of the abdomen. Thanks to these lines that you have it, yes? So this umbilical line is passing through the L3, L4, also it's important landmark of this line. This is the same explanation that we say. Another classification that is most commonly, and the details they are explaining, is horizontal lines that they are defining the 3 regions. One is above this subcostal line is called epigastrial region or epigastric region here in the center. Then between the subcostal and the bispinal line is umbilical region, and between the bispinal line till the symphysis pubis, here it's the pubic region. So in the midline you have these 3 regions. So, but generally the upper region is called epigastrium, the middle region is called mesogastrium, and the lower region is called hypogastrium. This epigastrium, mesogastrium, and the hypogastrium further is divided to the middle and lateral side. So the epigastrium, which was here, it is divided in the midline, in the center, which is called epigastric region, and lateral part, which is called right and left hypochondrium or chondriac region. So this is the part, the classification of the epigastrium. So regioepigastrica and hypochondriaca. Then the mesogastric region, which is here, is divided to the center, which is called umbilical region, and two side region, which is called right flank, or the lateral region also they call it. Right lateral and left lateral, or right flank. The hypogastrium, it's the area that in the center region is pubic region, and in the lateral one is the right and left inguinal region or groin region also is set. So this is the classification as a 9-region pattern. So you have the 4-quadrant pattern for explanation of the reason, and you have the 9-region that the epigastrium as a 3-region, mesogastrium 3-region, and hypogastrium 3-region. So this is important. Like a thoracic wall that we described the layers, so you have to know also when you are dissecting the dead body or you are operating the person, so what are the layers from superficial to the deep region? So first layer is a skin, as you know. This skin is in the epigastrium, is movable, and thanks to the fatty tissue that they have and loose connective tissue that it has in underlying structure, which is the subcutaneous tissue, and then is the superficial abdominal fascia. This subcutaneous connective tissue, it contains a lot of fat tissue, which is called Camper's layers. Is very important. And this is, in this Camper's layers, there are passing superficial vein and arteries, like superficial epigastric artery, superficial epigastric vein, or superficial circumflex iliac vein and artery. And also the innervation of this area in this subcutaneous tissue, they can find some nerves that there are branches of the intercostal nerve and subcostal nerve. The lymphatic drainage is going to the upper part of the abdomen above the umbilicus is going to the axillary lymph node, and the lower part of below the umbilicus is reaching to the superficial inguinal lymph node. Then, after that, you have the Scarp's fascia. So this is the Scarp's fascia in this region after the Camper's fascia. So then you have the Scarp's fascia, which is together with the superficial fascia of the subcutaneous tissue. So subcutaneous connective tissue under the skin is divided to the fatty layer, which is called Camper's, and it's called the connective tissue layer, which is called the Scarp's fascia. That in the scrotum, Scarp's fascia is synonymous of which layer of the scrotum? Oof. Scarp's fascia, you know that layer of the scrotum is continuation of the anterior wall of the abdomen, which is going to the scrotum. And each layer has synonym with the scrotum. Final exam is closing. Yes? 1, 2, 3? My God. Yes? Tunica dartus, yes. So it's the smooth muscle that is making a contraction of during to the regulating of the temperature. So, so this is the subcutaneous. Then, after this subcutaneous Camper's fascia and the Scarp's fascia, then you will reach to the muscular layer. And the muscular layer in the anterior region is rectus abdominis, and in the lateral region continue as obliquus externus, obliquus internus, and transversalis abdominis. And there are the arteries and veins that they are passing here. They are the deep vessels, and the lymphatic vessels in these deep layers, they are going to the lumbar and external lymph node. Here was the superficial and axillary lymph node for the upper part and lower part. And innervation again in intercostal, subcostal, iliohypogastric, and ilioinguinal nerves that they are coming from lumbar plexus. After the muscular layer, in thorax, we had the Which fascia after the muscular layer in thorax? Which is, if you penetrate it, you go to the parietal pleura. Which fascia was? Endothoracic fascia. Here you have transversalis fascia, or another name for the transversalis fascia is endoabdominal fascia. That was endothoracic fascia or endoabdominal. Here is transversalis fascia or endoabdominal fascia, which is important. And then after that, there is some extra peritoneal fatty tissue or fascia is located, and then you reach to the parietal pleura. And if you cut this part, then you are entering to the peritoneal cavity of the abdomen. So layer by layer, if you go, the skin, Camper's fascia, Scarp's fascia, muscular layer, then the transversalis or endoabdominal fascia, some fatty extraperitoneal fatty fascia, and then parietal peritoneum, and you boom to go to the peritoneal cavity. So those are the layers that you have to be able to describe. There is one interesting in the anterior side of the abdomen, interesting organization of the rectus sheath, which is important. In the upper, there is a different organization for the upper 3/4 of the rectus sheath, which is here, and the lower 1/4 of the rectus sheath. And you see the arrangement, how it passes. You know the aponeurosis of the external oblique muscle here is continue over the rectus abdominis muscle. Here is the rectus abdominis muscle cross section. For that, we are talking about the upper 3/4. Yes. So here the aponeurosis of external oblique is going over. Then you have aponeurosis of the internal oblique, which is a split over and below the rectus sheath. Very important. And then the transversalis fascia, the upper third. So it's going under the rectus sheath, and then you have the endoabdominal or transversalis fascia, and then there is a peritoneum. And see, in the lower third of the, or lower quadrant of the abdomen, yes, you see all the aponeurosis of these three muscles, they are just going over the rectus sheath. No aponeurosis is going behind the rectus abdominis muscle in the lower quadrant of the anterior abdominal wall. Extremely important, because here in the lower abdominal wall, behind the rectus sheath, there is nothing else than transversalis fascia. Yes? And then is parietal peritoneum. Yes? This is very important, and the border between the upper 3/4 of the rectus sheath and the lower 1/4 of the rectus sheath, there is a place here which is called arcuate line. This is the arcuate line which is determining the 3/4 and the 1/4 lower. Yes? Arcuate line. This is the important and this arcuate line approximately in the midway between the umbilicus and the surface of the pubic symphysis. Yes, so this is the one important. As we said it about the thoracic wall, then when you explain the layers and you explain also this rectus sheath, then you have to say about the innervation, blood supply, and the lymphatic drainage and lymphatic drainage. So the nerve supply, as you see, for the abdomen is again intercostal nerves that from the level of T7 till T11, and the subcostal nerve, which is the ventral branch of the segment T12. Those are innervating the skin of the, and of course the motoric innervation of the muscles of the abdominal wall. Another two nerves that they are arising from the lumbar plexus, and you will see it, they are arising from segment L1, and they are iliohypogastric nerve and the ilioinguinal nerve that you remember that it passed through which lacuna or compartment? Ilioinguinal? Yes? Lacuna vasarum is genitofemoral nerve, which was the femoral branch of the genitofemoral nerve. But then at the superior level of the superior, anterior superior iliac spine, there it's the ilioinguinal nerve in the lacuna musculorum, in the lateral side, yes. So be careful also. Lymphatic drainage, it's divided to the superficial system and deep system. We said superficial system is draining in above the umbilicus. It means this area. They are going toward the axillary lymph node, and below the umbilicus is going to the superficial inguinal lymph node. The deep system above the umbilicus is going to the parasternal or the internal thoracic lymph node. And the deeper one is going to the lumbar, and the inferiorly is going to the external iliac lymph node. The artery blood supply of the abdominal wall, superior epigastric, we mentioned, branch of the internal thoracic, very important, is the end branch of the internal thoracic artery. Internal thoracic artery, it has two end branch. One is superior epigastric, and the other is the musculophrenic artery. Those are the two end branch of the internal iliac artery. Then is inferior epigastric, which is anastomosing with the superior, is a branch of the external iliac, together with the deep circumflex iliac artery. So they are giving the around the iliac crest, deep from the external iliac. Then you have superficial. You see the difference between them. You have to dissect it here. Above the inguinal ligament is external iliac artery. It gives these two branches, the deep circumflex and the inferior epigastric. After the inguinal ligament, the name is changing and is becoming femoral artery. And femoral artery is giving superficial circumflex iliac artery. And also the superficial epigastric artery is superficially supplying this. Of course, there are the intercostal posterior and subcostal and lumbar in the deeper area. There are branches of the descending aorta also supplying of this area. We mentioned it again that behind the rectus sheath, two superior epigastric artery from internal thoracic artery and inferior epigastric artery from the external iliac artery behind the rectus sheath. So it means that if you cut the rectus abdominis and you elevate it, behind of that you have to find this passage of the inferior epigastric artery. And if you continue, you will see that they are anastomosing together from above the superior epigastric. Remember this one. This is your task in dissection exam. Venous drainage, we divide them to the superficial and deep. And the region that is above the umbilicus and the region of the below the umbilicus, above the umbilicus, they are going through the thoracoepigastric vein and lateral epigastric vein. Below the umbilicus, they are superficially, they are going to the superficial epigastric, superficial circumflex, and superficial external pudendal, some small part for the genital. The deep venous, again, above the umbilicus is the superior epigastric, below is inferior. Here you just see the superficial one. And the lateral posterior is draining to the intercostal and lumbar. And important is in the deep part of the peritoneum, there is paraumbilical veins. In the chapter and in the lecture of the veins, we are going to discuss that these paraumbilical veins, they are a tributary of the portal vein, and it's connecting to this superficial vein, which is the superficial epigastric vein, and thoracoepigastric vein here. So if there is a problem with the liver, for example, alcoholic people or liver with the cirrhosis or the hepatitis, if the liver is not working or in any reason, the pressure of the portal vein, it will be increased. So those veins that they are anastomosing, the superficial vein, like a superficial epigastric and thoracoepigastric, around the umbilicus, they are becoming dilated, and they are looks like a hair of the witches, which is called caput medusa. This is very important. If you see around the umbilicus, there is a dilatation of the varicosis vein, superficial vein. This is the connection of this superficial vein with this paraumbilical vein, which is connecting to the portal vein. We are going to discuss it. This is one of the places of the portocaval anastomosis, which is extremely important. Remember of portocaval anastomosis, the places, extremely important. Of course, the weak area of the abdominal wall, there are several parts of this abdominal wall. They have the weak place that they are usually is the area for the formation of the hernia. Yes, and this famous one, they are umbilical. At the level of linea alba, the inguinal canal hernia is common also. We are going to discuss femoral canal and so on that you will see here that it's can happening as a name. Umbilical region, as we mentioned it, is a place of the mesogastrium. And in the center, so superiorly is epigastric region, inferiorly is pubic region, and laterally is right and left lateral region or the flank region, yes, or lumbar region also they call it, yes. This umbilical region, of course, it's a place that there are some vessels in embryonic life. They are passing as umbilical arteries and umbilical veins. And around in midline, there is a linea alba abdominis. We have linea alba coli in the neck, but here is the abdominis. There is a circular opening here, which is called umbilical ring or annulus umbilicalis. And this umbilical vein is carrying and is transforming after the birth to the round ligament of the liver, which is ligamentum teres hepatis. So it's one of the ligament of the liver, which is the remnant of the embryonic umbilical vein. Umbilical arteries, that there are two usually, and they make the fold, which is called medial umbilical fold in the inner surface of the abdominal wall, where it's after that is covered by the peritoneum, and they make the fold, which is very important, which is called medial umbilical fold here. So medial umbilical fold is made, this fold or pellica is made by the obliterated umbilical artery, as you see here, and here you have it. Then we have another fold that I will explain it to you, is very important. Another fold which is here is the lateral umbilical fold, which is a passage of the inferior epigastric vessels, and one is in the center, which is the median umbilical fold, which is the remnant of the chorda urachus, is obliterated of the urachus in embryonic life. Finally, in the umbilical region, the transversalis fascia at the umbilical region is called umbilical fascia. So, and this is a region that sometimes you can it can appear the umbilical hernia. So you see that in this region there is a herniation of the connective tissue or soft tissue, or sometimes some part of the intestine is entrapped in this region. This is a very important fold in the inner aspect of the abdomen when it's covered by the peritoneum. So you see we have 5 folds. One is in the center, which is called median umbilical fold, here in the center, median umbilical fold. Then we have 2 medial umbilical fold, and we have 2 lateral umbilical fold. Yes, so 5 fold in the inner surface of the abdominal wall at the region of the umbilical, lower part of the umbilical region. Lower part, yes, here. This fold, the median one, is the place of the obliterated urachus. Middle one, be careful of the median, and middle one is the place that is passing umbilical arteries, obliterated umbilical arteries. And the lateral part is the place that it passes, yes, inferior epigastric vessels. Yes, remember of this. Between these folds, 3 and 5 folds, there are some fossa. Between the median and medial, there is a supravesical fossa. Between the medial and lateral is the medial inguinal fossa, extremely important for hernia. Yes, it's called Hasselbalch triangle. And finally, lateral to the lateral umbilical fold is the lateral inguinal fossa, which is a place for the position of the deep inguinal ring. Here is the place for the position of superficial inguinal ring, and it also is a place for the hernia of the inguinal canal. They ask you in the exam. So here is the explanation of these folds and this fossa, which is very, very important. Inguinal region is a region that we studied is in the hypogastrium, and in the lateral side is called groin region or the inguinal region, and is the region that is passing the testis. You know, the testicle and testis is located at the level of approximately L1 in abdominal cavity, yes, but by the age of the 28 weeks or after the 32 weeks, so this testis is must descending to the scrotum, in the scrotal cavity, yes, this is one of the important pediatric examination in the children, that you have to touch the scrotum if the testis is located in the scrotum or not. This is an examination in pediatric. If you go, definitely you have to do it, of course, in the boy. This testis, or descending of this testis, is passing through this inguinal canal and through the place which is the spermatic cord is passing. So the inguinal canal, which is located in the inguinal region, in men, it contains spermatic cord. In women, there is a place that it passes the round ligament of the uterus, or ligamentum teres uteri. And in both sex, inside the inguinal canal, there is an ilioinguinal nerve. Extremely important. Here, immediately I ask you, you are fresh. Ligamentum teres uteri, or round ligament of the uterus, is inserted to Three weeks ago you had the genital organ practical. Insertion of the round ligament of the uterus Only 1, 2, 3? Yes, David. There? No. Yes? There? Yes, labia majora, the external genital organ of female, the labia majora is the insertion of that. So, we said that this is the inguinal region that is in the hypogastrium, in the lateral side. It's called also the groin region, and the border is superiorly is the bispinal line above, and below it's the upper border of the pubic ramus, or the ramus of the pubic bone, and medially is vertical line of the continuation of the medioclavicle, and laterally it's the inguinal sulcus. So the content we said, and now the inguinal canal is complicated, and you will do dissection, and this is because it's clinically is important because a lot of hernia is happening here and classified as a direct and indirect, and you have to know the difference between the direct hernia and indirect hernia. This canal is approximately 4 till 5 centimeter from here till here, and is located in the abdominal wall above the inguinal ligament, and is going obliquely, as you see, from the superior, lateral, posterior, is going downward, medially, and anterior. So the obliquely is located, is 4 till 5 centimeter, and it's from the superior, lateral, posterior, is going to the inferior, medial, and anterior direction. It's the place where these two muscles, the internal oblique and transversalis fascia, this fiber of these muscles, they are not extending no longer in this area. So this is one, and here is just a place which is composed of the aponeurosis of the obliquus externus, and inner surface there is a fascia of the endo-abdominal fascia or transversalis fascia, and then peritoneum. And here you can see this spermatic cord of the male. It's passing through this inguinal ligament, and if you want to classify the wall of the inguinal canal or inguinal canalis inguinalis, the superior wall or the roof is made by the internal oblique and transversalis abdominis muscle, which is the continuation of these two. They are fusing together and they make the inguinal falx inguinalis. In the chapter of the ligament, you should have the lecture of this wall of the abdomen. In inferior wall is made by the inguinal ligament. Anteriorly is aponeurosis of the external oblique abdominis muscle. And in this anterior wall, you can find the superficial inguinal ring or annulus inguinalis superficialis, which is exiting of the, here, it is exiting of the inguinal canal happening. Posterior wall is made by the transversalis fascia, which is entrance to the canal, it is, and there is a place which is the deep inguinal ring is located here. The deep inguinal ring is located here, annulus inguinalis profundus. The men, we said that is a spermatic cord, and in the female there is a ligamentum teres uteri. The round ligament of the uterus is passing through this canal, And remember that in this spermatic cord, in the chapter of the genitals, we have the content of the spermatic cord. We have artery, testicular artery, the main one, the artery of the ductus deferens, and the artery of the cremaster, three fascia and cremaster muscle, nerves, genitofemoral nerves, which is innervating the cremaster, and sympathetic nerve and ilioinguinal nerve. They are passing here together with the vein. What is the name of this vein? Plexus. 1, 2, 3, 4, 5. This side? This side? What is the plexus that is passing through the spermatic cord? It's continuous as a testicular vein, and it's draining far. It's called, yes? Pampiniformis plexus, yes. Thank you. So here is written the round ligament of the tres, which is inserted or ends to the labia majora, is important. And of course, in both sex, men and women, we have the ilioinguinal nerve from the lumbar plexus that is just passing through the superficial ring is in the anterior wall, and it doesn't transfer through the whole canal. This is also important. So layer by layer, if you go, it's highlighted the most important thing. And first is superficial inguinal link, that ring that we said is in the place that is in the anterior wall and is the place for the exit of the canal. This ring is bordered by the medial crus, lateral crus, intercrural fiber, and the ligamentum reflexum, that in the chapter of the ligament you should have this one. Then the next layer is the inguinal canal, which is going below or below the muscular fiber. And above the canal, medially, we have the inguinal falx or falx inguinalis, and is extending to the inguinal ligament. And the last layer is the section above the inguinal ligament, which is only you have transversalis fascia. And in this area, you have the fold which is called the interfoveolar ligament, or the interfoveolar fold is the ligament. This is extremely important, that the interfoveolar ligament in this area, which is in this area, in the interfoveolar ligament, there is passing the inferior epigastric vessels. This is extremely important landmark. We said about the inferior epigastric vessels is a branch of external iliac, is going behind the rectus sheath. So definitely in dissection exam you will find it. And when you find it, this passage that is coming in the inguinal region is the place that you can find interfoveolar ligament. So this is a landmark for you, yes? And when you find these vessels, lateral to that is the place of the deep inguinal ring, which is called lateral inguinal fossa. That fossa that it was, I mentioned it, between the folds, yes? Medial to this inferior epigastric vessels, there is a medial inguinal fossa, which is called Hasselbalch triangle, which is the place for the hernia. Hernia is, this is a ring, the deep inguinal ring, and here is the branches, is the supravesical fossa, and the lateral one is the lateral, the medial inguinal way. So here, epigastric vessels, you will find it in dissection. Lateral to that is the lateral inguinal fossa, is the place for the deep inguinal ring. Medial to that is the medial inguinal fossa, is the Hasselbalch triangle. And lateral to that, to the this epigastric. It's the medial to that of the umbilical artery or umbilical fold is the supravesical fossa. Those are the three places of the herniation that is very nice in this picture. You can see the hernia. What is important? You have to know there are indirect, direct hernia. Indirect hernia is the most common, and indirect hernia is usually congenital. It can be acquired also, and is passing through the deep inguinal ring, as you see here, and is just lateral to the inferior epigastric vessels, because deep inguinal ring is in the lateral fossa, inguinal fossa. Direct inguinal is usually acquired and is due to the weakness of the abdominal musculature. It's happening and is medial to the inferior epigastric vessel. So if you find the epigastric vessel and there is a herniation of peritoneal sac in this region, it's in the medial fossa or inguinal fossa, or the Hasselbalch triangle is located in this area. So direct inguinal hernia, it does not traverse the entire length of the inguinal canal. It's just located in the superficial inguinal ring. So from this slide, the most important, indirect, direct. Indirect is usually congenital. It can be acquired also. Is located in deep inguinal ring, lateral to the epigastric vessel. Direct vein is usually acquired, is the because of the weakness of that, is medial to the inferior epigastric vessels, or is in the Hasselbalch triangle, and it doesn't pass through the length, it's just coming out from the superficial inguinal ring. And this is more or less the same things that I mentioned. This is congenital and or acquired, and here is the direct acquired. And here is for comparison of the hernia in this area, the medial, lateral, supravesical fossa, the three fossa which is located in the peritoneal fold. And there is one in the saphenous opening of the greater saphenous vein when it's reached to the vascular compartment in the femoral vein. So there is another ring which is called femoral ring and is below the inguinal ligament. Those are the above the inguinal ligament, and here is the below inguinal ligament. Then we reach to the abdominal cavity. Abdominal cavity, we classified them with the different classification. One classification according to the abdominal and pelvic organs. So remember this quadrate pattern that you have it, and according to the position of the organs, we are classifying the organs by the layer. Those are the superficial layer or anterior layer organs. Here is the middle layer organs, and usually the deepest layer in the posterior layer, which is the kidney and retroperitoneal organs, and vessels, they are in this layer. And here is mentioned the structure that you have. Another classification of the abdomen and pelvic region is classified according to the level. We divide them to the upper abdominal, lower abdominal, and lesser pelvis. The cavities continue to the lesser pelvis. For the organs that they are located here in the upper, organs that they are located here in the lower, and in the lesser pelvis, in the pelvic region, those are the organs. Third classification according to the intra or extra peritoneal organ. For sure you had a lecture about the peritoneum, about the peritoneal cavity, and here is the intraperitoneal organ, and in the abdominal cavity, in the pelvic cavity, and extraperitoneal organ, which are here. Generally, the abdominal cavity if you find, according to the last classification, this green one that you can see, it's the peritoneal cavity. And what is, except this green one, is extraperitoneal cavity. This extraperitoneal space or cavity either is in front of the green, which is peritoneal, is periperitoneal space, or behind the peritoneum, this blue is retroperitoneal space, or below the peritoneal cavity of in the pelvic region, which is called infraperitoneal or subperitoneal area. Yes? This is a nice classification or pictures that is showing you the important and classification according to the peritoneum. So green one is the peritoneal cavity we are going to discuss. In front is periperitoneal, behind is retroperitoneal, and below is infra or subperitoneal with the organs that we mentioned it in the table. Yes? Peritoneal cavity, that was green one. Here is the cross section, and it's very important cross section. Be careful of this cross section. Yes? The peritoneal cavity divided to greater sac and omental bursa. This is a space, it's called omental bursa, and the rest, which is here, all is the greater sac. This is two main classification of peritoneal cavity. Yes? We are going to discuss one by one. This is the same picture with the details, and here is the cross section through the omental bursa or lesser sac here. And remember, the inferior level of the peritoneal cavity, which is in female, is end up to the Douglas pouch. If you remember, the rectouterine pouch, very important. And this is the deepest peritoneal cavity in the female. And here we have the vesicouterine pouch. In male, we have only one pouch or excavation, which is, we don't have uterus, of course, so it must be between rectus and urinary bladder, which is called rectovesical pouch. Those pouch is very important for rectal examination or vaginal examination. If there is any fluid, let's say that you have appendicitis, the exudation is secreting to the peritoneal cavity, yes, and the fluid, it must be according, I'm standing, if there is some fluid in the peritoneal cavity, it goes according to the gravitation to the deepest part of the peritoneal cavity, which is, in this case of the woman, is Douglas pouch here, yes? So if you go to the emergency with the acute abdominal pain, immediately they do rectal examination, which is through the rectum, or in case of the female, through vagina. You can touch this rectouterine pouch. And if there is an exudation, the patient is jump 1 meter up. For us is immediately a sign of emergency. They take him to the emergency, sonography, blood test, and this thing. Because they take the blood test to see the inflammatory parameter, but it takes time. The laboratory will come to this and it can be ruptured of the appendix. So that's why the first thing that they do is the rectal examination that they do. And it's giving you very important, because you touch this one, if there is any accumulation of the fluid here, you can be diagnosed. The omental bursa, the lesser sac, this is a border, is the space that is behind the stomach. So those are the border. I put it in the table for you, and definitely you have to know all this border of the omental bursa. For the anterior side, lesser omentum, posterior one, the retroperitoneal organ, the superior is the visceral surface of the liver, inferior one, the transverse mesocolon, and the left side is the spleen, and right side is the liver and duodenal bulb. In the right side, there is a foramen, which is epiploic foramen or Winslow foramen, or the here the omental foramen, which is the natural place that is communicating to the omental bursa in this region. Is very important. And here there are some recesses, as a superior recess, inferior recess, and splenic recess in the left side. Those are the significant recesses. The recesses, they are between the two peritoneal fold or between the organ and peritoneum. Yes? So, and those are the places that they are interrupt the pathology. Yes? There are strangulation can happening, it can be some herniation happening. So that's why it's important to know the recess, that is there are accumulation for infection, abscess, or inflammation, or neoplasm, and so on. So this is the omental bursa that we are saying, and this is the cross section for the recess that we said. Here is the subphrenic recess under the diaphragm, and here is the subhepatic recess, that one of the part of the subhepatic recess is the hepatorenal recess that we mentioned it, and in the left side is the gastrosplenic recess or space that is located here. Then those are the lines that we already explained, and those are the landmark of this line, and this is the cross section that is telling you the bursa omentalis and the lesser omentum. Here is very nice. You can see the lesser omentum. It's the place, is the duplication of the peritoneum, which is connecting the lesser curvature of the stomach, which is here, connecting to the visceral surface of the liver as a gastrocolic ligament, a gastrohepatic ligament, and gastroesophageal ligament. Some book they write it or esophagophrenic ligament. But the most important ligament here is which ligament it contains this tree structure, which is called porta hepatis. Is a question that in oral examination, if you do not answer, finish. Yes? Yeah? Splenoduodenal? Hepatoduodenal ligament is. Content of the hepatoduodenal ligament, remember, posteriorly portal vein, anterior and left side proper hepatic artery, anterior right side is common bile duct. Very important. Inside of the hepatoduodenal ligament is a part of the lesser omentum. This is the same cross section at the level of T12-1 that you can see the surface of the position of the liver, and you can see the omental bursa, and behind the omental bursa then there are the retroperitoneal organs, which included the abdominal aorta and the right side, the inferior vena cava, and of course the primary retroperitoneal organ, which is kidney. The dissection of the peritoneal cavity, I hope you had a lecture about the greater omentum and lesser omentum. Those are the information that I don't repeat it in systematic anatomy. This is the cross section that already I mentioned it, that the peritoneal cavity was dividing to the greater sac and lesser sac, and this peritoneal cavity also it's divided via the attachment of the transverse mesocolon to two parts, the supramesocolic compartment and inframesocolic compartment is above the attachment of the transverse mesocolon and the below attachment of the transverse mesocolon. And those are the structure that you have it inside the supramesocolic compartment, and here is the structure that you have it inside the inframesocolic compartment. Then, of course, you have to know about the projection of the organ. First, spleen, to know that the axis of the spleen is copying the rib number 10. So the width of the spleen is located between the rib number 9 and rib number 11, but the axis is parallel with the rib number 10, which is called the splenic rib also. This is the first thing is important for that. Those are the lines that you have it here for the recapitulation, and one by one I'm going to discuss it hopefully. This is the surface projection of the organ. One, liver. This is the area of the liver. Liver, you know that the right lobe is covered by the ribs. The diaphragmatic surface is can be examined by the percussion approximately 13 centimeters above the anterior costal. But what is this? This triangle or oblique line, is the projection of the left lobe of the liver, which is connecting the cartilage of the right 9 rib to the cartilage of the 9 rib. So this is an oblique line which is making a border for the left lobe of the liver. Stomach projection is this triangle. This is called Labes triangle. This Labes triangle is inferiorly is the transpyloric line. Superiorly is the inferior border of the liver, left lobe, and the left side here is the left costal cartilage. This is the triangle of the Labes triangle and is projecting for the stomach. Gallbladder is the point here, which is called Morphy's point. Very important, Morphy's point. Morphy's point is the point which is medioclavicular line is connecting with the cartilage of the rib number 9. This is the projection of the fundus of the gallbladder, Morphy's point. Projection of the duodenum and pancreas. One projection is this one, which is called Desjardins pancreatic point. Desjardins pancreatic point is the place that in the major duodenal papilla, 2 main structure is open. What? Major duodenal papilla in descending of the duodenum, 2 structure they are open to the major duodenal papilla. This is a question, if you don't answer, definitely you will fail. Yes? Common bile duct and pancreatic duct, they are open to the major duodenal papilla or papilla fater. This is a point as a Desjardins pancreatic point. This is the line which is the connecting of the umbilicus here, this line, connecting of umbilicus to the center of the axilla, and from the umbilicus 7-6 centimeter is the Desjardins point. It is showing the point of the major duodenal papilla here. You know that the duodenum is making a loop at the level of L2, and at this level there is a head of the pancreas. This is the projection of the head of the pancreas. Then definitely you know about the McBurney's point and Lund's point. This is extremely important. I hope you had it in the appendix. But the McBurney's point is connection of the right anterior superior iliac spine to the umbilicus, approximately 6 centimeters from the spine. It's the beginning of the appendix in this region. And there is a Lund's point, which is here, is a bispinal line, is a right lateral third of this bispinal line is the Lund's point, which is usually determining the end of the appendix, which is the below appendix. Of course, the appendix has several positions that you had it in the lecture, and here is again the McBurney's point that showing with the other organ that I mentioned. This is again some sclerotopic landmark to orient the important structure. For example, L1, we said that it passed through the transpyloric plan or gallbladder fundus and renal hilus, and this is the pancreatic head, which is in the loop of the duodenum, or the duodenal window is located at the level of L2 below the L1. It's passing. Those are the surgical procedure through the omental bursa, that we said that the natural one is the epiploic foramen or Winslow foramen, which is the only natural entrance to the bursa omentalis is, and supra-mesocolic compartment blood supply is by the celiac trunk, the venous drainage to the portal vein, very important portocaval anastomosis at the level of the cardia and the esophagus. Here, it's important. We are going to discuss it in the venous things. Again, be careful. Portocaval anastomosis here at the region of the cardia, of the stomach and abdominal esophagus. Lymphatic vessels around the vein, and here is the table that I prepare for the quick revision of the blood supply, venous system, autonomic nervous system, and lymphatic drainage of the supramesocolic compartment. The inframesocolic compartment, also it's further is divided to the paracolic space, which is the external and internal, and external and internal in the right side and left side. The artery blood supply of the inframesocolic is via the superior mesenteric and inferior mesenteric. Venous, again, portal vein. Sympathetic and parasympathetic, parasympathetic by vagus till the left colic flexure, and lymphatic drainage is the mesenteric nodes. So this is a table, and here is the superior mesenteric artery, and here is the inferior mesenteric artery, which are the two main arteries for the blood supply of inframesocolic part. It means that below the attachment of the mesentery to the transverse mesocolon. The peritoneal fold and recess also, as I mentioned, is clinically important. This recess also either is between two folds of the peritoneum or between organ and peritoneum. And there are some folds or recess that is located, which is a site of the internal hernias or is site of the strangulation. It can happen. The most important one is superior and inferior duodenal recess. The behind of that is retroduodenal, and parallel with that is the paraduodenal recess. And here we have the retrocecal, the retrosigmoid recess, and in the second region we have the retrocecal and the superior and inferior iliocecal recess. The retroperitoneal is the organ that they are behind the peritoneum. If the organ is partially covered by the only parietal peritoneum, it's called secondary retroperitoneal organ. And if it's just is embedded inside the loose connective tissue of the retroperitoneal, is the primary retroperitoneal. And the content of the retroperitoneal here you have about the organs, vessels, and lymphatic, and this typical primary retroperitoneal, there are kidneys and adrenal glands and the vessels. The secondary retroperitoneal organ, who knows? Yes? Secondary. Kidney is not secondary. Yes? Pancreas and main part of the duodenum. They are the second, and the ascending and descending colon also. Those are the secondary retroperitoneal organ, which is here is mentioned. Here is the organ again inside the table. You have the organ, you have the vessels, and you have the nerve. You can make it as a reference for the summary. Cross section of the retroperitoneal, The kidney, remember and revised in the lecture, definitely you had the covering of the kidney. Yes, the fascia, the retrorenal, perirenal fascia of the kidney. Remember of the Grotthas fascia and Zuckerkandel fascia that we mentioned it before in the genital. And thank you for your attention and study hard.